Good afternoon, and we will now start the MDS Satellite Symposium. And before anything, I would like to thank Glam and the MDS Foundation once again for this seventh Latin American, well, symposium actually, on myelodysplastic syndromes. This is the Bristol Myers Symposium, and I have the honor to introduce Mr. Dr. Guillermo Garcia Manero. We all know him. He's a professor of leukemia, department of the Oncological Center of MD Anderson of the UT, and he's also a head of section of myelodysplastic syndromes in the leukemia department. Dr. Manero has received his title in the School of Medicine in Zaragoza, Spain. He was an intern at the hospital in Philadelphia. He completed his studies in hematology, and he's certified by the internal medicine board and oncology. He's an expert on MDS, AML, and others, and the molecular aspects of these disorders, particularly what's the role of epigenetic alterations of leukemia. So, Dr. Garcia Manero, the floor is yours, and thank you very much for your participation. Thank you very much for giving me the opportunity to participate here. I understand that it was supposed to be in Uruguay. I've never been there, but I would have liked to be there with all my colleagues and friends. My job today is describing what's going on in low risk MDS. So first, we will start by defining what's low risk in MDS, what this means in general, and what are the goals that we could have as therapy. The definition could be a multiple definition. Questions that we have is there's CHIP or CCUS that could be considered low risk. If we use the IPSS classification, low and intermediate one, if we use the IPSSR, it's very low, low, and some cases of intermediate. We will discuss this later on. And something important is to know if this is pre or post HMA failure. Now, regarding the goals, of course, we need to consider the improvement in transfusion requires, quality of life, survival, if it's OS versus event-free survival, and maybe a delayed type to transformation. And maybe it's time to think about other molecular endpoints that can serve as surrogates. And something that I won't dwell on today is the influence of treatment on the comorbidities that these patients have. This is a scheme as to how we see the treatment of MDS patients. This is something that I published in the American Journal of Hematology. Let's focus on the left, lower risk patients of any age. The treatment that we will discuss are growth factors, maybe iron collation, luspatercept, HMAs, lenalidomide for a deletion of 5q and others. And then in some patients going to the transplant, bone marrow transplant. I mentioned at the beginning that it is important to mention what happens before and after HMA, because it is important in those patients who have low risk HMA failure are those patients who are still low risk, quote unquote, and they don't have such a poor prognosis. The other question is, what are these patients dying of? This is a paper that we launched 1 decade ago. I don't think this has changed a lot. Most of the patients with MDS eventually die of MDS or infection. 15 to 20%, they transform into AML. They have bleeding disorders, and this is a very important point because it means that if you are dysplastic and you want to improve the natural history of this disease, you have to emphasize on the treatment and not transformation. Our group for a long time has been interested in dividing these patients into different subgroups. This is an old classification, but still useful with low risk dysplasia. It's based on cytogenetics, cytopenia, blasts, and the point here is that there's low risk with good characteristics, with score, well, survival without treatment is long. We see that there are patients with these characteristics who have a survival of 1 year or even less. So this is what we know now as low risk but with poor prognosis, especially important for one of the pieces of data that we will discuss then. In terms of transformation to AML, this is obviously a problem. It happens in 10% of patients, maybe 20%. You cannot predict because they have excess blasts, some cytogenetic alterations like chromosome 7 alterations at the time of diagnosis. When the IPSSR classification came about, there were differences in wondering if those patients were low or high risk. Dr. Benton published this paper, and those patients could be divided into two groups: intermediate low, intermediate high. People speak about 3.5 points up or down, maybe dividing this subgroup into patients who have a more benign prognosis and those who are considered to be high risk in this IPSS classification. And of course, this will change when we start to incorporate some molecular data. And this is also an old publication of Dr. Behar, where we see that while we accumulate mutated genes, and these are the 17 genes that Rafael analyzed back then, the prognosis goes down. And these are patients who have 4, 5, 6 mutations, and they even have a worse prognosis. Dr. Bravo at the MD Anderson has similar data where there are patients with low risk characteristics, cytogenetic low blasts, but they have more than 3 mutations. They have a very different prognosis from those who have 1 or 3 mutations. So low risk patients are classified by IPSS, IPSSR, and you can change the classification depending on the alterations, and knowing that the prognosis of these patients is not such benign as we thought. Now I would like to start with my talk. I have created a hypothetical case, maybe to gear the conversation through my talk. We start with a description. It's a 60-year-old female, presents to the clinic for a second opinion regarding a new diagnosis of DEL 5Q MDS, is anemic, but no transfusion is given. Otherwise, she's asymptomatic. Bone marrow exam at the center confirms diagnosis. The NGS panel is negative. WBC and platelet counts are in normal range. Hemoglobin 9.9. Questions are, first, what should I do? Observation, close observation, and starting an ESA when they are transfusion dependent. Maybe proceed directly to allo-SCT, maybe wondering what happens if we start with lenalidomide or decitabine or luspatercept. Low risk, no transfusion, and alteration of this chromosome. This past year at ASH, one of the most interesting presentations of these past years has been presented by the Spanish group of MDS. This is a very important study, by the way. These investigators ask themselves, makes sense to start lenalidomide in these patients with alteration of del-5q who are not dependent on transfusions. The regime is as follows. Randomizing patients with low doses of lenalidomide compared to placebo. And their response, though it still is partial and interim, is interesting. Those patients who received lenalidomide initially before receiving transfusions, they had a transfusion-free period that was longer than those patients who were delaying the use of lenalidomide because it's a lot of time. So this is important. Maybe early intervention in this group of patients could be important. Of course, for patients who are depending on transfusions, Dr. Fenot is one of the speakers at this conference years back, published this study, which is randomized phase 3 of lenalidomide in lower risk del-5q MDS. He confirmed the he's confirming these outcomes, these results. An important piece of information is that the cytogenetic response is important. I always think that this is our chronic leukemia in MDS. These are data presented by Dr. Sequeres, where those patients who had a cytogenetic response had a better survival and prognosis than those who did not have this response. So I guess that then we should start lenalidomide. If they respond well after 5 years, this patient now turns into someone who's dependent on transfusions. You repeat the bone marrow, there's no evidence of progression. They still have a del-5q, and the NGS panel is still negative. Ferritin level is elevated, it's 2,000, and the question is, what do you do? So you start ESA, you proceed with transplantation, increase lenalidomide, you start with decitabine, luspatercept, or iron chelation. So let's see what's the answer. First, reviewing very fast all those data that we have with growth factors. So these are European studies with 12 or 13 years with a combination of EPO and GSECF, where there was a potential to improve the survival of these patients, specifically in patients who had a low need of transfusion. These are very important pieces of info. In those patients who debuted with transfusions, the use of growth factors is maybe associated with an improvement of the natural history. This was published 2 or 3 years back by Dr. Plasbecker comparing placebo with carbopoietin. Darbepoetin, the interesting thing here is that none of them have shown that the use of these growth factors changed the natural history of our patients. And this is why there is a need to discover new drugs. The important question is the role of iron chelation. We've been discussing this for almost 20 years, and the opportunity together with Dr. Angelucci et al. Was Telesto, a randomized study, chelation against non-chelation with transfusion-depending patients. It was published in the Annals of Internal Medicine last year. Initially, was planned to be bigger, but we didn't include all the patients that we wanted because our colleagues were already divided between those who are in favor or against. So it was very hard to challenge this. We have those patients who had received chelation Deferasidox was the drug, and there was an overall survival result. It was not statistically powerful enough to show this effect. Our group at MD Anderson, which is not someone who's prone to collation, we started to reconsider the use of collation, especially in patients who have an important transfusional load because they might have elevated ferritin levels. And then the response would be after, of course, failing lenalidomide, you would start with growth factors, collation, and then after 6 months, the patient remains transfusion dependent. So at that time, you repeat the bone marrow exam to see if there's progression, and you get a surprise. There's some ring sideroblasts, and there's a new mutation, which is the SF3B1 codon 700. So question is, what would you do with this patient who has already received ESA, an erythroid growth factor, and suddenly she comes with this mutation particularly and evidence of ring sideroblasts? The question would be, proceed to allo-SSCT, start oral decitabine, or start luspatercept? This is one of the compounds which, after 15 years, were approved in the US for patients with MDS, something that was very important to us. This is a very interesting drug which alters the signal by TGF beta. It's a study by Dr. Battalier in Houston. He profiles the alterations of TGF-beta and the therapeutical and clinical gain by blocking this particle. The effect regarding erythropoiesis is the maturation or allowing the maturation of erythropoiesis in inhibiting this pathway. Here we see what are those molecules that are activated by TGF-beta and what are the downstream signalings affecting these signaling pathways. And you can then hypothesize that they are capable of inhibiting these signals since they are blocking TGF-beta to their receptors. So based on this, concepts, there are some drugs which are structurally interesting, which inhibit the signaling of these pathways, joining the ligand, the ligand that's activating this pathway, this ligand which is involved in the pathway activation. It's fusion proteins containing this activin type 2AB that you can see here in the structure. It's quite a novel concept, blocking different ligands that will eventually activate this TGF-beta pathway. And since it is inhibited, the hematopoiesis will be restored. After a series of studies both in animals and phase 1 and phase 2, there were two compounds, luspatercept and nuspatercept. This is the medalist study being developed. It's a very interesting study because it resulted in the approval of this drug for MDS patients. And then it was a plenary paper in ASH, something that did not happen for a while, and an article in the journal. These are the phase 3 results of luspatercept against placebo in patients with refractory anemia with ring sideroblasts who had already failed growth factor, or who else were no candidates for this. This is the design of the study. That is important to see what's the group of patients who are treated. You see here that these are patients with 5% if there's the SV3B1 mutation. There's no alteration of 5. The IPSS are very low, lower intermediate risk. Patients who have not responded to prior ESA before or who have a level of EPO which is more than 200 ULs. They had to be dependent on transfusions and have not received treatments before or HMAs or IMID or lenalidomide. They were randomized 2 to 1 luspatercept, 1 milligrams per kilograms every 21 days, or placebo. It is important to see when they use this compound that the dosing of this drug could be increased depending on the answer up to a maximum of 1.75. An injection for 3 weeks up to doses which might be escalated depending on the answers or the reaction. The primary endpoint was the red blood cell transfusion independence equal or greater than 8 weeks. And the key secondary endpoint, red blood cell transfusion independence equal or greater than 12 weeks, weeks 124, 148. So these are the characteristics of the patients. 76 placebo, well, it was well balanced, and the mutations. Now, regarding the treatment exposure, which is a very important piece of information, those patients who are capable of completing 24 weeks, it's 83.7 against 90%, approximately patients who were more than the time scheduled. You can see what's the percentages, 1.33, 1.75. So in the end, many of those patients escalated the dosing depending on the response. So the initial and primary outcome concluded that this drug was approved in the USA. This is represented here, and the responses that were independent of transfusions, more than 8 weeks, it was 37.9% in luspatercept compared to 13.2 in the group of placebo, and this was highly significant. 13% of patients in the placebo group responded, and this was quite a surprise. So it is important to follow them enough time. No doubt that luspatercept was associated to a better response in terms of transfusion independence. This is a different way of visualizing these results. This is the reply 8 weeks, 12 weeks after. So we see that there's a clear difference in terms of acquiring positive responses. A very important point, and this is a very busy and important slide, is the dynamic of this response. More than 8 weeks without transfusions. In this slide, all the patients responded. These patients achieved an interval where there were more than 8 weeks transfusion-free. So each red dot is a transfusion, and blue, no transfusion. So you can see how long a period they have been without a transfusion. If we go to this level here to the right, we see that there are patients who are still having transfusions. Eventually, they were considered to be responsive to this criteria. This is important because in some patients, they are still getting clinical benefit, though eventually throughout the administration of treatment, they need transfusions. Well, this is very important indeed regarding the use of this compound. Now, what are those endpoints which are associated to a better or worse response, considering patients who have a minor transfusional load at the beginning of luspatercept, they might have better outcomes. If you remember some minutes ago, I was discussing EPO, GCSF, and we saw the same phenomena. Those patients with a lower transfusional load, they had better answers and responses. So in my opinion, I think that this compound plays a role in patients early on with less transfusional load. And this is why I'm interested in this study, which is now open, and it's randomizing first-line luspatercept against erythroid growth factors in patients who are dependent on transfusions. I think that this drug is very active, but we need to go beyond and see what happens with the outcomes. Everything favors luspatercept, and this is another way of seeing the transfusional burden of these patients, and it favors patients who have been treated with luspatercept. Remember that they were transfusion dependent and they have failed one drug before, one growth factor. So this is the erythroid response. This is the hemoglobin levels. These are changes in the hemoglobin concentration. Of course, now regarding transfusions, there has been a clear improvement with this drug. What is the toxicity of this compound? And in our experience, as expected, this is an extremely benign toxicity profile without level 3 or grade 4 toxicities and without evidence that this compound could be associated to progression. It's very safe. Of course, a patient, if we remember our case, had she been treated with luspatercept because she had this mutation and she had ring sideroblasts and so on and so forth, and you start luspatercept, and after 12 months of treatment, after achieving independence, the patient loses a response. Bone marrow exam shows 3% blasts. Cytogenetics remain del5q negative, but the NGS panel now shows a TP53 mutation at a low BAF. This is not something that would associate luspatercept with this, but this is just to follow the course of the patient. Platelet count goes down, so the question is, what should we do? Proceeding to allo-SCT, starting HMA, or considering investigational agent. So now I will focus on the course of these HMA drugs in low-risk MDS. This is something that is very frequently used in the US, and the question is, what is the dose and the schedule of these drugs? And what we saw with lenalidomide, we can use this type of compounds early on. We can even consider some patients who are transfusion dependent, and we can understand the systemic effects of these HMAs in low-risk patients. This is something that has started 15 years ago. This famous study of Dr. Lyons taking a look at different levels of azacitidine and seeing that these patients, instead of 7 days, 5 days, and they had low risk, as you can see here at the right, they had better responses, better tolerance as well. So my group started to work with developing these drugs, this HMA first, AZA, oral AZA, which is this famous study that was approved for AML last year. There were significant responses, 50% approximately, in patients with MDS. Based on this concept, we start to take a look at low dose of DAC in LR-MDS. It is important because we saw that with a pharmacokinetic response of oral AZA, the exposure was low. Maybe lower doses of this drug could be associated to a good activity and lower toxic profile. This is the overall survival that we started to report. And eventually, we carried out this randomized phase 2 study of low-dose decitabine versus azacitidine in patients with low risk. And what we saw basically is that the responses were very interesting, with 30 to 40%. The survival was better than expected in those patients who had a poor risk because of the classification of the MD Anderson. Then we have the early intervention in transfusion-independent PTS with low-risk MDS treated with lower doses of HMAs in association with high response rates and long duration of response. And this year at ASH, we hope we can present initial results of this multi-center phase 3 study of the American group of myelodysplasia, comparing low risk to different ways of administering these drugs, as ASA 3 days, DAC 3 days, and ASA 5 days compared to observation. Of course, I don't have the outcomes here. This is a very important study.
I believe that the next thing that will happen, that will be very important, will be the inclusion of these hypomethylating agents, oral drugs, to our patients. Because in low-risk patients, this could really, change the natural history and facilitate treatment. Nowadays, we have two of these compounds. The first one is the citabine oral, or ACTX2727, approved in the US last year, together with luspatercept and CD486 for acute myeloid leukemia. This was a randomized study we did, but looking mainly at the pharmacokinetic profile, comparing the IV versus the oral version, the citabine, and we saw that the pharmacogenetic profile and pharmacodynamic profile was 99%. So these drugs are identical. In ASH, that's this last year, Dr. Savona, another leader of this study, showed that these drugs has clinical activity, that it's identical to what you would explain with the citabine IV. So this drug, the citabine oral, it's in the United States. It's starting to be used. The other very important compound, obviously, is TC4X6. Today, we're not going to talk about the role of this drug in acute myeloid leukemia. I'm very proud of these results because they were almost 10 years of my work. We have just published in the GCO the results of phase 3 in myelodysplasia. So what we saw with this study, with this LabSat MDS003, these were patients with low-risk myelodysplasia, but all of them with these bad prognosis characteristics that we discussed previously, with the severe thrombocytopenia, etc. So they were randomized to oral azacitidine versus placebo. And one of the problems we had here is that instead of using the 14 days we used in acute leukemia, we developed a dose of 21 days, a little high for these patients. But what we saw, for example, was that the erythroid responses in this study were significantly higher with ASA orally, 31% against 1%. And we saw very similar responses as well at the platelet level. So in terms of response, there's no doubt that this compound was highly important. However, we didn't see an improvement with regards to the survival, and that we will see later on because of a little early toxicity with this type of compounds. Something that is very important here that we can see in this slide is the duration of the erythroid response, 11 months against 5 months, highly significant, obviously. So I believe now that we are starting to be in these hypomethylating agents. Amphetamine oral has been proved. Cetirizine orally, we need to continue doing studies to understand its role, and obviously a very important role in acute myeloid leukemia. So we started this patient with a HMA, the citabine, azacitidine, or any of these oral compounds if you have access to them, and they improve with the transfusions. They eventually, you repeat the bone marrow, 3% blasts. You can see that the mutation of P53 starts increasing, and the question now is, well, what do you do when you start seeing at not response to the HMN? Well, you could say, well, what happens if we increase the dose? We're giving low doses. What happens if we have access to an investigational agent? First, and very important, is to see that the prognosis of these patients with low risk and poor HMA failure that Dr. Ure mentioned 1 year ago. Well, the base thing is to take these patients to bone marrow transplantation. This is not something that we can do that frequently given the age of these patients. Our group is studying many different drugs that are summarized here, like drugs that inhibit Ribon 4, interleukin 1, interleukin 6, etc. But these are very initial pieces of data that it's not worthwhile to discuss now. The other question would be, which are the transplantation data? Well, this is a very important slide, is the study of Dr. Correth from the IBMTA 1 week ago, in which we do not see that there is a clear role for patients with low risk using the transplantation at the beginning, non-transplant with transplantation, but in my opinion, those patients that have already received treatments like this, like the treatment the patient we discussed received, obviously they have a benefit in their survival if they have a transplantation at that point. And now to wrap up, thinking that some of these patients have mutations that you might use, like IDH1, IDH2. There are data CD47, a series of the drugs that block CD47. It's important to do molecular tracking to see if to see whether there is an option for any of these drugs, no, and maybe this could have a role in our patients. And to finish, maybe to summarize the treatment algorithm, 20 or 21 for low risk patients. For patients with delta skew, myelodysplasia, like anemia, like the only cytopenia, in the first line, lenalidomide, second line, HMA, maybe transplantation. Patients that only have anemia with bad risk characteristics and without an alteration of the chromosome A5 growth factors in the first line. Second line, HMAs. In some patients that have more than 100,000 platelets, we will conceal another bit, and then transplantation as allo SCT. The indication will be in patients with refractory anemia with ring seroblasts that have received an ESA or that are not candidate to these growth factors. A new indication would be luspatercept if they do not respond or fail in the response, HMA, maybe lenalidomide, SCT, and then for the other patients that have severe cytopenias, bilineal, maybe we will start with HMAs first and then SCT in considered mutations like ADH1, ADH2, P53, maybe for these drugs or for clinical trials that are being used for this type of patients or groups of patients. So to conclude, maybe what we have learned is that there might be a role for the early treatment, especially in these patients with alteration of chromosome 5. They, they we have more data on the iron chelation. It's something old, but it seems to benefit a group of these patients. We have discussed new drugs like luspatercept, maybe the new development of these methylating agents. I think that we need new drugs for second-line patients, particularly after the HMAs, and we also we need to have better guides for the incorporation of the bone marrow transplantation in these patients. And with this, I would like to thank you for this opportunity and send you my greetings from Houston. Thank you very much. Very well. Thank you very much for your presentation, Dr. Manero. So let's go to the Q&A session now. We are going to open our page, and in the meanwhile, I would like to ask you if the burden of the SF3B1 mutation has an impact in the results with luspatercept. Thank you, Alicia, for this question. No, it doesn't have an impact. Indeed, I believe that luspatercept is agnostic of having these mutations. The indication nowadays in the United States is in patients with refractory anemia with ring sideroblast. 80% of these patients have this mutation. But I believe that luspatercept will have a role outside this group of patients as well, in patients, low-risk patients with anemia, regardless whether they have this mutation or not. Great, thank you. Dr. Jorge Albervide is asking the following: what treatment would be adequate for a patient with MDS with ring sideroblasts and the presence of the mutation SF3B1, DMT3A, and CMPL? And what fails in the ESS and ESAs and the combination with the lenalidomide? There's no availability of luspatercept for this transfusional anemia. Well, obviously, I believe that the only agent that you won't be able to consider is an HMA, the cytarabine or azacitidine. The question would be what dose? And in our center, these type of patients will be treated with lower doses of these compounds, like 3 days of the cytarabine, 5 days, sorry, he corrects himself, 3 days of cytarabine, 5 days of azacitidine. That would be our standard guide, maybe 5 days at the lower doses of these compounds, but the answer is HMA. I personally will reduce the dose or the number of the days of administration for these patients. Great. Dr. Veloso is asking whether a patient with the 5q deletion and non-transfusion need, but with a TP53 mutation, did you start with lenalidomide? Did the Spanish trial try that? This is a fantastic question. We wouldn't use lenalidomide in this patient in particular. That published a few years ago in very important papers in New England Journal and other publications of this level showed that maybe lenalidomide could had a pressure on the stem cells that might have this mutation of P53 and in some way make this mutation and this clone to increase in its level. But and indeed, we have seen cases in which patients treated with lenalidomide eventually might develop some type of myeloid leukemia or myelodysplasia with a mutation. So even though there's no real prospective data doing what the doctor was saying, we wouldn't use lenalidomide in a patient with a P53 mutation, even if they have low risk and they are positive for chromosome 5 and they have this mutation. If they have this mutation, we would fear that this clone might progress if we do that. The question, if you allow me, Alicia, it has a very important corollary here, which is that no, we need to make sure to do a mutational profile in these patients, because if you only look at the SF3B1 mutation or you don't have a mutational profile, you will lose this point of information that is critical to know whether they have the mutation. The truth is that most of these patients have a very low mutational burden in this context. Probably they will have very low mutations, as Dr. Veloso has said, and we are not sure about the implications of this type of phenomena. But in principle, we wouldn't use lenalidomide in these patients. Okay, great. Dr. Sofia Grille, the use of lenalidomide in patients 5q minus without transfusional dependence, it's not approved in lenalidomide. After knowing the results of the Central Ref study, do you use it? At what dose? 5 milligrams orally per day? We use, well, the data were presented actually in December in ASH, in the ASH, so it was very, this presentation was very important for us because it has a concept that for us is very important, which is the early intervention in patients with myelodysplasia. In my center, traditionally, we have done this with hypomethylating drug, azacitidine at low doses. With lenalidomide, the data go in the same direction. What happens if you started treatment initially early and there might be a very significant clinical improvement? So I have treated a couple of patients in the last few months with these, with a 5 milligram dose. Basically, we do what the Spanish group did in that presentation. We're doing the same. Okay, great. Okay, is there a place for using luspatercept in patients with low risk, no 5q that have failed EPO plus GCSF and azacitidine? Is there any data of the response post failure to HMA? That is a very good question. In our practice in the US, I believe that a large majority of the patients that we have treated with luspatercept outside the clinical trial, once the drug was approved, is exactly what this colleague is describing. They have failed erythroid growth factor and probably have used an hypomethylating agent, because in the US we use these drugs frequently for low risk patients. We have not we are not have noted down these results. We are thinking about having a series together, but the answer, in my opinion, is related more to the transfusional burden of the patient. And in the presentation I try to stress this. In patients that have a transfusional burden of less than 4 units, even if the patient has failed an HMA, I think that it is possible that they might have a response if we use the compound probably. In patients with a transfusional burden that it's larger, maybe the response might be lower in that group of patients after an HMA, but this hasn't been studied yet prospectively, because the drug has been approved 6 months ago. But this is a very good question for those patients who use HMAs. I don't see the contraindication of using the compound. Obviously, we use it very frequently in this group of patients. Excellent. The other question is, in your experience, do you have cases of patients with 5Q minus that do not respond to LENA, but they respond to EPO? This is described, and there are data that there might be a synergy between the two compounds. There have been several studies, not exactly what you have said here, but combining an erythroid factor with a drug like lenalidomide, they might have a synergistic effect and they might recover the response. It's interesting as well that if we start talking about the combination of luspatercept with these erythroid growth factors, because they act at different levels of the erythropoiesis cascade, and there is some data that indicate that there might be a synergistic additive result if we provide these two growth factors in a parallel manner. These are interesting things. The issue is the cost of this type of combination, and the fact that we do not really have clinical trials that are showing the activity of what we are talking about. That's true. That's true. You are right. The other question is, if in these patients with thrombocytosis and ring sideroblastic anemia, what is the response they have to luspatercept? That's one of the indications. I mean, there wouldn't be any type of problem in using this compound luspatercept in this group of patients. And obviously, these are patients with a natural history that are a little bit different, maybe more benign, but it would be a good option for treatment as well for that group of that specific group of patients. Okay. And Francinel is asking, what is your opinion about venetoclax in MDS refractory to hypomethylating agents? No, well, obviously the symposium is about low risk. So my opinion, venetoclax, which is an inhibitor of BLS2, doesn't have any role in low risk patients, because you might think that it might even suppress erythropoiesis. So it doesn't have a role. Now, with regards to the question in a more global way made by this colleague, the data of venetoclax in second line in failures for hypomethylating agents were presented a couple of years ago in ASH, and the response is very low. I don't see then a clear role of venetoclax in patients with failure, HMA failure of high risk, and I wouldn't use it in low risk patients either. No. Okay. Now, the other question, and this is my question, you expect to have some sort of a pathological response in the rest of the series with luspatercept, as we can see in in patients with progeny That's a very good question, Alicia. Actually, we knew from the beginning that there were sporadic trilineal or bilineal responses with luspatercept. And one presentation in ASH last year with a summary resulted in a paper that we are just producing, trying to summarize this data. It's difficult to measure, because the studies of luspatercept were not designed to really measure the response with regards to platelets or white cells, but you can see responses in the leukocytes and the platelets, but it's not the primary objective of this treatment. What I mean is that there's no sense in starting luspatercept to see whether there is a response in platelets, even though occasionally you might see it. I believe that the message or the conclusion of this question, which is very important, is to know that the drug will not damage the other lines, right? For example, with lenalidomide in patients with a significant thrombocytopenia, you might induce leukopenia or thrombocytopenia. We haven't seen this with luspatercept. In that sense, then, it is a very safe drug in patients that might have leukopenia and thrombocytopenia that are moderated. In that case, I would maybe go for another type of compound. Well, this is the end of the symposium. Thank you very much for the excellent presentation, and let's hope that very soon we will be able to see each other face to face. Likewise, and I send you a big hug to you all, and thank you very much for the opportunity. Great.